Good afternoon, everyone. My name is Jessica Biggs, and on behalf of Global Genes and Orphan Disease Center, it is my distinct pleasure to welcome you all to our conversation on equity and ethics in context. Thank you so much for taking your time to join us. Before we get everything started and kicked off, I just want to review a bit of brief housekeeping notes. The chat box to the left of the video allows you to interact with each other and program staff, and we hope that you use this opportunity to make some new connections. Please note that links and resources are not able to be shared via the chat. If you would like to upload any shared resources for the community, please share those on the social wall. The questions box is located to the left of your screen. We encourage you to use the questions box to share your questions with the presenters. This is your time to find answers and insight to help you advance your work as a partner in research. Please note that the speakers will not be able to see any questions in the chat box. Rather than the official question section. If you are not able to address all questions, we will be able to use our best to follow up with you. To the right of your video, you will see captions and translations. To utilize either, please expand that session and select your language. Thank you to Horizon and Greenwich Biosciences for their support of these tools. If you have any questions about the technology or the program, please look for the request support button in each session for the live support chat. Finally, we encourage you to participate as an active listeners and take advantage of any opportunity to hear from leaders and experts here and ask questions from them. We want to ensure that we have created a relevant and impactful program for you and greatly appreciate you sharing your time with us. I am pleased to introduce myself. I am Jessica Biggs. I recently joined Angioma Alliance as their program health equity development specialist and outreach specialist. I'm working to launch the Breaking Barriers program. Angioma Alliance is a patient-centered organization working to improve the lives of CCM patients. The Breaking Barriers program will focus on understanding the barriers to diagnosis and detection in the African American population. I have worked also in maternity health equity in the past, and I'm really grateful to be here with you all. I also would like to introduce my co-chair, Rodney Sacamo, to kick off the first segment on building foundations for success in clinical. I think that was wrong. Sorry. I also would like to introduce Dr. Zaidi, who is a pediatric hematologist for the Children's Hospital of Michigan. So I will turn it over to him now.
Thanks for that, Jessica. Hi, everybody. Firstly, thank you to the meeting organizers for including me in this important symposium. It's a pleasure and honor to be here. My name is Ahmar Zaidi. I'm a pediatric hematologist at the Children's Hospital of Michigan in Detroit, Michigan, where I have the privilege to care for about 800 patients with sickle cell disease. Today, I want to spend some time giving you the context of sickle cell disease in this very important conversation that we will have over the next 45 minutes or so. So we're going to talk today about what I refer to as the sickle cast. We're going to talk about the single mutation, the road to victimization, and the road back. I am going to go ahead here with my slides. Here are my disclosures. You know, I have a bigger disclosure to make to you today, and that is in 2014, I took an implicit association test. And that implicit association test told me something that I wasn't expecting to find out about myself. When I took that test, it told me that I have a slight preference. I favor white individuals more than Black individuals. Now, that was really difficult for me as a person of color to see. And I decided that I was going to change the way I do things after I recognized that this is a problem. See, as a person of color, you assume that you're free of implicit biases, that you're free of bias in general. But I was so wrong. And as a doctor in inner city Detroit, caring for largely African American and some Hispanic patients, I could not allow for my own bias to get in the way of my ability to treat sickle cell patients in a socially responsible way. So I started changing the way I practice medicine. And what I did is become really, really thoughtful about the bias that I had. So when I give this talk, I'm speaking to myself to remind myself about my bias and what I'm doing to acknowledge my bias. I speak to myself as much as I'm speaking to you today. Talking about implicit bias is difficult. It certainly has triggered doubt and fear in me, and can trigger defensiveness. But this is not going to be a personal attack on anybody, not even myself, right? This is not personal. We're here to have a really important conversation about implicit bias and how it can play into rare disease and the care of patients with rare disease. I'm going to start with a poem. This is a poem by a famous American poet named Langston Hughes. Freedom will not come today, this year, nor ever, through compromise and fear. I have as much right as the other fellow has to stand on my 2 feet and own the land. I tire so of hearing people say, let things take their course. Tomorrow is another day. I do not need freedom when I am dead. I cannot live on tomorrow's bread. Freedom is a strong seed planted in a great need. I live here too. I want my freedom just as you. You know, the first story of sickle cell disease in the Western medical literature is celebrated. It's a story about a 20-year-old named Walter Clement Knoll in 1904 who comes to the United States of America to further his studies as a dental student. Walter Clement Knoll arrives in the city of Chicago, where he is struck by an episode of pain, walks in, and is seen by an intern who does everything that that intern should have, orders all the right tests, and even does extra tests, including looking at Walter's blood under the microscope. This, of course, unlocks the crucial finding in sickle cell disease that Walter's red blood cells were the wrong shape. This case gets published in 1910, and doctors around America start saying, wow, we have patients just like Walter. You know, but something about Walter always has bothered me. You know, the way Walter was treated in 1904 as a Black man in Chicago was different from what I had come to see as normal of how sickle cell patients were treated in our country in this century. You see, there's a very different story around sickle cell disease. And when you dive into the literature, things become a little bit more clear. You see, in 1846, there's a report that's lost in the literature. And this is the case of the runaway slave. This is a story of a man who tried to escape the plantation, was eventually caught and then executed. And during his autopsy, is found to have leg ulcers and an absent spleen. This, in fact, is probably the first description of a sickle cell disease patient in the United States of America. And this, of course, is more congruent with what we have come to expect of sickle cell disease in this country. You see, there's no glory in sickle cell disease. And we can't have a conversation about sickle cell disease without having an open and honest conversation about racism in the medical field and acknowledging that the American healthcare system has been built on discriminatory and racist structures. When we talk about racial health disparities and its effect on quality of healthcare between minority and non-minority patients, the difference really comes in threefold, right? So the first is just clinical decision making, and the second is patient preferences. Now that contributes to the disparity a little less. What we're talking about today, though, is the operation of healthcare systems and the legal and regulatory climate, and we're talking about discrimination based on biases, stereotyping, and uncertainty, and how they contribute to racial health disparities. And this plays out in every realm of healthcare. Forget rare disease. This plays out in common disease, right? This plays out in cardiovascular disease, where Black patients are 3 times more likely to develop and 2 times more likely to die from. They're less likely to receive treatment of choice. They're less likely to get preventative measures. This shows up in kidney disease, where Black patients are more likely to get dialysis and less likely to get life-saving organ transplant. This shows up in cancer, right? The National Cancer Institute says, as long as Black patients get equal care to white individuals, the survival rates are the same. But we know the survival rates are not the same because Black patients get diagnosed later, they get less treatment, and they get less intervention. Right? This continues to play out in things like obesity, childhood obesity, diabetes. This plays out in maternal health, fetal health. This plays out in mental health. In fact, the only two things that Black patients are more likely to get than white patients are amputations of their limbs and antipsychotic medications. We have a problem. In 1999, Schulman and colleagues did a wonderful study looking at cardiac catheterization rates, and they presented these 8 actors shown on this screen. And then they presented essentially vignettes that looked identical, more or less. The correct sort of life-saving procedure for these patients would have been cardiac catheterization. And what they find in a study of 700 plus cardiologists is that the person most likely to get the cardiac catheterization was the white male. And the person least likely to get cardiac catheterization was the Black female, showing that race and gender can contribute to these types of decisions in the hospital. Now, this shouldn't come as a surprise to anybody. See, in 1851, Samuel Cartwright, a slave physician, coins a term called dysesthesia aethiopica, where he says Black slaves have thicker skin. And the only way to fix that is to whip them regularly and to induce pain because their skin is thicker. 1851, right? And you'd say, well, this is the year 2021. Things certainly are different now. Well, shown here is a study by Hoffman and colleagues that looked at the general population, looked at first through third year medical students, and looked at residents in the year 2017. And what we see is that 20% of the general population still thinks that Black nerve endings are less sensitive than white nerve endings, and that Black skin is thicker than white skin, 60% almost of the general population. And look at the resident rates here. The residents still believe that Black skin is thicker than white skin. The medical students still believe that Black skin is thicker than white skin. Yeah, that slave physician coined that term in 1851, but man, we have not been able to shake that off yet. We are still struggling with that mentality. So COVID hits us, right? And this pandemic sort of changes life as we know it. And the media starts creating this narrative of, well, the Black population is getting hit harder. And it's true. The Black patient population is certainly struggling. But they're coming at this news angle as though it's news to us, right? As though sickle cell physicians haven't been dealing with this from the beginning. We know that the system is broken. We see it every single day. So of course we knew that the Black population was going to be the one that gets hit hardest, right? When we look at this overrepresentation of the Black community, see the red shaded columns here represent overrepresentation of that population in that state amongst death. And you see in the top 10 states with mortality, the Black patient population is grossly overrepresented when it comes to deaths from COVID-19. The healthcare system is broken and does not know how to provide care appropriately to these communities. But this is a reminder that we didn't need, right? We didn't need the pandemic to tell us this, right? Because we get these reminders regularly. We get reminders, unfortunately, that inequality from a racial standpoint exists in this country. So in May of this year, for 8 minutes and 46 seconds, George Floyd, with a knee on his neck, says, "I can't breathe," 20 times. And the entire country erupts, right, into social justice, Black Lives Matter. And the only thing that I could think of, honestly, was my sickle cell patients. Because, yeah, George Floyd was murdered with a knee on his neck saying, "I can't breathe." But that fight is happening in hospitals with sickle cell patients, right? George Floyd saying, "I can't breathe" out there is the same as my sickle cell patient with debilitating pain being in the hospital saying, "I'm in pain," and nobody's believing them. right? In fact, when you think about sickle cell disease, a disease where these disc-shaped, smooth red blood cells become these sharp daggers that get pumped through the body, they rip through the organs, they cause pain, they cause blockages, right? They cause blockages that don't allow blood that has oxygen in it to go forward. Literally, sickle cell disease is the physiologic manifestation of I can't breathe. You know, this should have been expected because the signs were on the writing was on the wall the whole time. Right? Linus Pauling tells us what the molecular defect in sickle cell disease is in the 1940s. And on 1951, in this news clipping, you see a quote from Nobel Prize winner Linus Pauling, where he says, "I agree, we should keep these carriers from marrying one another. I've advised, not entirely joking, that individuals should have tattooed on their forehead symbols for the defective genes that they carry. Or better, to tattoo the symbols in Braille on their abdomen," right? So if we talk about stigma, the man who was celebrated, who fell in love with the mutation that caused sickle cell disease, didn't fall in love with the people who had sickle cell disease. And this shows up through the literature. We see this. We see when, ER physicians or hematologists are asked if their patients are addicted, they often say, yes, my patients are addicted. They're addicts. They don't have a real disease that's causing them real pain. This is addiction. And we know, if we look at national databases, that sickle cell disease patients, even if you correct for race, wait 25% longer on average when they hit the emergency room, despite the fact that national organizations across sort of every country say that the standard of care is that sickle cell patients in pain should get pain medicine within an hour of hitting the emergency room. Well, Paula Tanabe and colleagues showed us that in North Carolina, that's not the case. Patients there are waiting 2, 3, 6, 8, 9, 11 hours to get their first pain medication as their body is literally being strangulated from the inside. We also see from Hood and colleagues a study on perceived stigma and perceived bias. When patients feel stigma and they feel bias, their quality of life deteriorates. We see the red line here indicating individuals who perceived that they were dealing with stigma in the healthcare setting. They were dealing with bias in the healthcare setting. And we see how that looks with quality of life. And we see their quality of life drops in this red line as they get older, knowing that they're being stigmatized in their healthcare setting. The green group's the opposite. These are the people with sickle cell disease who are saying, I don't have any stigma in my healthcare setting. There's no bias here. They're not feeling it. Their quality of life continues to improve as they get older. This is fascinating. When we look at quality of life in general for sickle cell disease, you may not have an idea of what that looks like. Well, from a physical standpoint, this is what it looks like. What we see in the top here, the green, is children. And what we see in the yellow is adults. When you look at healthy children, close to 90, healthy adults close to 90, the lower that QOL score becomes, the lower their quality of life. You see in pediatrics, having cancer and getting chemotherapy is the same quality of life as having sickle cell disease. When you look at adults, in fact, having cancer and getting chemotherapy is actually better quality of life than sickle cell disease patients. This is not the narrative that's out there, right? This is not what people believe about sickle cell disease. This is a devastating disease. We know that many of the roadblocks that we see in diseases in general really come from lack of research funding, lack of support to generate new and novel ways to care for these individuals. Well, in 1970, I think this is 1967, I'm sorry. In 1967, we have Robert Scott telling us the lay of the land. And he says, volunteer organizations in 1967 raised $1.9 million for cystic fibrosis, $7.9 million for muscular dystrophy, but less than $100,000 for sickle cell anemia. Well, a lot has changed from 1967 to 2021, right? Well, not really. Here's a study from J.J. Strauss that shows us what the lay of the land is in 2017. And we see when we look at the total funding of individuals with sickle cell disease Okay, let's back up a little bit. There's 100,000 individuals with sickle cell disease in the United States. There's a child born with sickle cell disease every single hour in this country and every 2 minutes worldwide. 30,000 individuals with cystic fibrosis in the United States. So let's look at the funding difference here. Total funding per person affected with sickle cell disease is $943. And when you compare that to cystic fibrosis, total funding per person affected is $10,592 for cystic fibrosis. This is a disease that really doesn't affect the minority population, and this is fantastic for cystic fibrosis. We know what's happened in cystic fibrosis over the last 10, 15 years. And that story looks very different in sickle cell disease. FDA-approved therapies are coming regularly for cystic fibrosis. Things are looking a little different, and we love that. We want that. That's what we want, right? We want that prototype to come to all rare disease. Sickle cell disease struggles far behind because we have a difference in funding of this magnitude. And this shows out in mortality, right? So in the hashed line at the bottom here, we see pediatric mortality has definitely improved because of penicillin, because of, lots of physicians who care for pediatric sickle cell disease. But adult mortality, man, adult mortality is a different story. Look at this. The adult mortality is climbing in sickle cell disease. We have a real problem here. Adult patients can't find doctors that want to take care of them, let alone find treatments that work for them. Well, you may be thinking, well, Dr. Z, this is interesting and all, but what exactly can we do about implicit bias and racial health disparity? It's implicit, it exists, but how do we fight it? Well, let's talk about that. In 2007, Green and colleagues provide us lots of insight in this matter. They look at individuals requiring breaking of clots, specifically in the cardiac setting. Okay. And what they do is they take a group of doctors and they ask them, do you have a bias? And the doctors, being doctors, say, absolutely not. We're physicians, we're bigger than bias, right? We don't see color, quote unquote. Yeah. So explicitly they say no. Then he makes them take the implicit association test, the same one that I took in 2014. That changed my life. When they take the implicit association test, he categorizes doctors by those who have high anti-Black bias and those who have low anti-Black bias. And what he finds is surely in this top right square here, individuals with high anti-Black bias were less likely to offer life-saving thrombolytic therapy to Black patients and more likely to offer it to white patients. But he did something unique here. He told a proportion of physicians what this experiment was about. He said, we're testing this. We're going to see who has implicit bias, and then we're going to see how it affects what they do. And when he told that group, a small group of individuals, that was what was happening, this is the lower right column here, the lower right box. Even the physicians with high anti-Black bias, once they knew that they were being looked at for this, changed how much thrombolytic therapy they gave their Black patients. They increased their proportion significantly. So what does that tell us? Well, that tells us that this problem that we think is not beatable, if we just don't talk about it, it doesn't exist, is the wrong approach. Because people can recognize and modulate and counteract their implicit bias as long as we're having conversations about it. So what I'm here to tell you today is we need to normalize bias. We need to be able to say all of us have bias, every single one of us. And that needs to be a normal thing. What we need to do is say, I have a bias and this is what I'm doing to counteract it. When we look at the model of racial health disparities, there's a lot of points where physicians or individuals, institutions can intervene to stop those racial health disparities. It can be at the patient level to help reduce the amount of physiologic or psychologic stress induced to patients by discrimination. It can be at the physician implicit bias level to ensure physicians are making decisions knowing what's in their blind spot. And it can also be at the level of discrepancy in how patients and physicians communicate, right? The ability of physicians and patients to communicate across racial boundaries with cultural competency on the table changes the way that whole environment, the whole model looks, right? So reducing the amount of negative patient reactions reduces the amount of racial health disparities. So what I'm going to talk to you today about, what I'm going to briefly give you today is some strategies to combat our implicit bias. And it's very easy because the acronym is implicit. So introspection, that's the ability to say, I have a bias. I'm okay saying that. I'm telling you, as a practicing physician today, I have a bias, right? I'm trying to normalize this for you too, right? Mindfulness. So finding ways to de-stress yourself, honestly, as a physician or as anyone who's in a position of power has been shown to reduce the amount of reflexive decision-making that we take. Perspective taking, considering experiences from the point of view of the stereotyped patient. And this can, for me, this comes in the form of spending time with my patients, right? Really learning about them, understanding who they are. Learning to slow down, pausing and reflecting on biases before making an action, right, has been shown to reduce the impact of implicit bias. Individuation, right? We're very good as physicians at putting people into boxes. And when we do that, we really are prone to making reflexive decisions. But evaluating people based on their personal characteristics, what they do, what their family life looks like, who they are, what their interests are, individuating that patient in front of you really makes a huge difference. And checking your messaging, embracing evidence-based statements, staying true to sort of the science and the consensus ways of managing patients helps reduce implicit bias. Institutionalizing fairness, promoting procedural change at the organizational level that moves towards socially accountable healthcare. And then finally, take two, practicing cultural humility is really a lifelong process. This is something that we should reflect on every single day, every single day. So implicit. Now, my colleagues Pat McGann and Alex Power-Hayes created a framework to help with sickle cell disease in the United States. And it looks at three levels: reducing the impact of structural racism on patients with sickle cell disease. And this is looking at social determinants of health, really. It's looking at funding at a federal level, right? It's looking at support for sickle cell patients. Then the second one being dismantling institutional racism with a focus on sickle cell disease. And this looks at sort of creating hospital-based safety nets that look at, race-related behavior, inappropriate race-related behavior, and safe reporting of that. The creation of anti-racism task forces, empowering patients to be able to safely report their concerns without fear of being retaliated against. And then finally, addressing the interpersonal racism that happens with patients in the medical context with nurses or physicians, ER physicians, often struggle with this, using things like the word sickler, making people their diagnosis, right? Or ensuring that we're speaking explicitly about race when we're talking to trainees, when we're talking to our colleagues, not creating this fallacy of colorblindness. Now, as we wrap up, I want to leave you with this quote from Thurgood Marshall. He says, "I wish I could say that racism and prejudice were only distant memories. We must dissent from the indifference. We must dissent from the apathy. We must dissent from the fear, the hatred, and the mistrust. We must dissent because America can do better, because America has no choice but to do better." And with that, I'm really excited about our question and answer session coming up.
Wow, thank you so much, Dr. Zaidi. I learned a lot from that presentation, and I really truly found it amazing. You really were able to show us those drastic parallels between care for African Americans and for whites, even though it's not new. It's still shocking to see on paper, right? And the work that you talked about with implicit bias and how it's unconscious, but we have to make the conscious effort to contradict those. So I would like to welcome everybody to go ahead and start asking questions in the Q&A panel. And then we can really, dig deep into this conversation. Alrighty, so we already have our first question. It is, it says, understandably that the minority communities do not trust medical institutions and hospitals. How as a rare disease group can we regain that trust in the minority patient communities?
Yeah, be present, right? Mm-hmm. Be present. I mean, there's no shortcut here, right? It's you have to put in your time with the community that's stereotyped and marginalized. And honestly, that's what made me a better physician is spending time with the patients, being in the community, right? Like creating that type of relationship is the only way that you're going to get to that point of creating trust. Because rightfully so, that bridge of trust between the healthcare, the sort of industrial healthcare complex and patients has crumbled, right? And it's because there's very good reason for that. So the onus is not on the minority population. The onus is on us, right? Yes. It's on the people on the other side to go out and bring them back in. We have to make amends. And a lot of people, colleagues, I've had colleagues say, well, we weren't part of that, like that. We didn't do that. So why should we have? Well, that's not really the point here, right? The point is we're trying to get to a better spot. And the only way that we're going to do that is by being able to swallow our ego a little bit and get out there and sort of really make it known that we're champions for these stereotyped and voiceless populations.
Yes, definitely. I always feel that it's important to do the work to warn the trust. You don't want to just be like, oh, we need them to trust us, but you're not on the other side making sure that when patients come in, they're not having these horrible experiences, right? They're not being misdiagnosed. They're not waiting longer. So it's like, what do you do on your end to fight the implicit biases, to become more culturally competent so that when patients come in, they're more willing to come in,
Absolutely.
So we have another question. The question is, there is so much fear from minority communities to walk into the ED and visit genetics to share their thoughts. How do we, as a system, make change? It also says the barriers are so many. How do we do this systematically and with intent?
Yeah, that's a difficult question, but I think that we really have to start mandating this probably, I would say, I'll tell you, in sickle cell disease, trying to get this mandated as federally and making it a priority for, our patients. I think that's going to be our approach. We have the National Academy of Sciences lay out a blueprint, and HHS was very much involved in getting that report out to create a strategic blueprint to get us to a point where we can do what's best for the minority communities. I think regulation at that level is going to be necessary. There's going to have to be some quality metrics that hold hospitals and hold healthcare systems accountable for not paying attention to their minority patients or their rare disease patients, or biases of any sort, really. So I think that would be my best answer. What do you think, Jessica?
You kind of covered it all, or not all, but you made a good point. And one thing that stood out to me in your presentation was that when doctors saw that they were being monitored, right, they automatically started doing more. So even that monitoring from the federal government or from whoever, so that doctors will put their best foot forward, so to speak.
Yeah.
So I think that
absolutely. Is great. Absolutely. I think that's my favorite slide too.
Yeah.
I think it gives you a little bit of hope.
It does. It definitely does. Okay, so we have a Couple more questions rolling in. So in the context of genome editing and the development in technology, what are your fears / concerns or even hopes to help avoid further disability, discrimination, and racism? Any suggestions on how to approach this in academia?
Yeah, I mean, again, bringing in the context of sickle cell disease, gene therapy is a hot thing right now in sickle cell disease. I mean, we're all talking about it. It's like on the horizon. It's happening. I mean, there's patients who are getting it. But of course, there's fears, right? There's fears of the unknown always, right? When it comes to, we should also we should not make light of the fact that every advancement that we've ever had in medicine comes on the back of patients who've taken a chance, right? It comes in the form of clinical trials where patients have said, yeah, I'll take a chance on this. So we certainly need to be able to engage the patient population a little bit more, I don't want to say aggressively, but aggressively, in the sense of like, you got to put in time with the patient community and really have them understand what the patients in their shoes have helped the sort of medical industrial complex accomplish before them, right? So we've had huge landmark studies, landmark progress in various rare disease. And it's come on the back of patients. And patients need to be given kudos for that, right? Because that's who we need. We need them. They have to be partners in this. And if they're not going to be partners in this, then we're not going to get far. For me, creating awareness of that concept that, this is yours, right? Like I'm here as really a passenger, right? But like the advancement that's being driven is being driven by patients. And we focus a lot in our conversations when we talk about curative therapies on transparency and why today looks different than 40 years ago, 20 years ago. We've seen this with the vaccines, for example, right? I mean, you saw the Johnson & Johnson vaccine have 6 blood clots happen out of 39 million doses that were given, and 6 clots in middle-aged women, and the whole program got shut down, right? Until they figured out what was happening. I mean, that's the kind of transparency that exists right now. The other thing that looks very different these days is there's a lot of people of color on the other side, right? Who are involved in a lot of these research advances. And I think having those types of open conversations, at least with sickle cell patients, has been really helpful. Love to hear from you, Jessica, on that.
Yeah, no, I definitely agree. I feel that having that, building that trust is part of kind of being transparent, right? Like I'm not going to do anything unless I know the steps and I know what's going on. I know what's happening, and building the partnership, right? I can't say like, I agree more. Like every time you're talking, I'm like, yes. So definitely, sorry, the questions are rolling in on the side. I'm like, but yeah, definitely I agree with that. And just like you said, being present, understanding, and building that partnership. So we also have another question. It says, thank you for your wonderful presentation. What are some of your recommended approaches that every rare disease organization should be doing for DEI?
Yeah, I think that depending on what the rare diseases that we're talking about, I'll draw an example from hemophilia. Okay. So many of my conversations with hemophilia doctors have resulted in conversations that are like, hemophilia affects every single race and ethnicity in equal proportions. So this really isn't a problem for us. Truly, we don't see color because this affects everybody equally. Well, that's hardly the point, right? The point is that your Black patient with hemophilia probably still has a significantly harder time getting treatment when they need it, accessing the resources that they need, having comprehensive care. So I think part of it is understanding the lay of the land, number one.
Mm-hmm.
Engage your minority patients that are part of your rare disease community and ask them. Ask them. Just say, hey, tell us, like, what is your experience? I mean, do you feel different in the emergency room? Do you feel different in clinic? If so, why? Right?
Yeah.
I think generating that first will give you what you need. See, as physicians, like if you're a surgeon and someone comes in, before you know what to operate or how to operate, you got to push on their belly to see where it hurts.
Mm-hmm.
Right. And that's kind of where we are here. You got to push on the belly first to see where it hurts. And you got to do that for CBOs, you have to do that with your community. You have to find out where it hurts first before you know how to intervene appropriately.
Yes, definitely. I like that comparison, right? That's something that we're doing in the Breaking Barriers project for Angioma Alliance in particular. We're taking a step before we launch everything, and we're actually doing patient interviews. We want to hear, how is your treatment? What happened? What happened to your aftercare? How did you feel? Did you feel supported? We're asking those questions, and we're already seeing some very similar threads. But like you said, it's important to take a step back and just ask them and talk. So we're at 5 minutes, so I'm going to read a few more questions. And like I said before, if we don't get to all of your questions, we're going to make our best efforts to connect with you afterwards and get those questions answered for you. So one of the questions that came in is, what are your thoughts on policy as it relates to introducing genetic technology and therapies to sickle cell disease? What are practical ways that the medical community can work towards minimizing implicit biases?
Yeah, so that's kind of a loaded question, but I think it echoes back to what we talked about a little bit earlier, in that holding people accountable, creating ways to have patients safely voice their concerns without fear for retaliation. Figuring out a way to, we have a little bit of a cancel culture situation going on right now. And like, one thing I want to make clear is, like, being a person of color doesn't give you a free pass, right? That doesn't automatically make you an advocate for DEI, right? Because, colorism is a real thing. And sometimes people of color can have implicit biases too, right? Against other people of color. Yeah. So being able to say that, number one, we should normalize that a little bit, where people are not so fearful of, like, oh my God, if I say I have a bias, I'm going to get canceled, right? Like, that's hardly the point. That's not going to help anybody. What we want is people to be able to say, I have an implicit bias. Please help me with this. Like, what do I need to do to make this better? How do I make sure this doesn't interfere with what I'm doing day to day, right? Like, that's the approach that I personally feel like works best for me. And that's what I currently try to do for myself. Now, federally, how do you instill that? How do you mandate that is a different question. Unfortunately, right now our political climate is very polarized, and the conversation around this has become really difficult. But finding champions in that gray zone that are not polarized completely on opposite ends, and trying to pull them in as allies is going to be important. I don't know how you mandate this federally or how you fix this, but those are just a few insights. Jessica, what do you think?
Yeah, kind of thinking about it and thinking about how you said walking around with blinders on. It's like we have to kind of stop that mentality. Like you said in your presentation about implicit bias, kind of acknowledging internalized racism and how that might play a role on implicit biases. That's a big thing. So there has to be a way to talk about it and get open without feeling that you're going to be canceled or people will look at you differently. It's like, I feel like when you make that conscious effort to get rid of those implicit biases, or not even get rid of them, but work on them and counter them, right? How do you go with your step forward to your employees or your staff and everybody and work through that? It has to be something that's done on the level with everybody involved. So I think that, like you said, that's a hard question. And it's not like one step it's multiple steps to figuring that through. And then what were some of your thoughts on policy as it relates to introducing genetic technology and therapies to sickle cell disease?
Yeah, it's challenging, right? Because we're working from a foundation where literally I showed you what Linus Pauling was saying about people who carry the gene, right? That they need to be tattooed on their forehead. And, you know, there was a real movement of like eradicating this disease and trying to finish this population off. So of course there's real concern. And any time that you are working, I don't want to say in the dark, but kind of in the dark. Like, I mean, this is a very new technology. This is something that is vetted, but also brand new. You know, this is a terrible disease. So I completely understand the people who are in favor of curative therapy, and I love the science of the curative therapy, but we have to be also very open and honest that this is new and it's going to take time. And you know, just being able to promise patients that we promise you full transparency on how this pans out, right? Like every step of the way, you're going to be there and you're going to know that this is what happened. This was what went right. This is what went wrong. This is what we plan to do about it. I think that I think that that'll get. I think that'll help pull people in a little bit more.
Yes, definitely. So even though we have a couple more questions, this kind of draws to the end of our presentation and our time with you. I really, once again, want to thank you so much, Dr. Zaidi. It was an amazing discussion and amazing presentation. And then, so for all of our audience members and everybody out there with us, before you move over to the next session, please take a few moments to respond to the polls that are being launched right now. We appreciate all of your feedback on the session and want to ensure that we are able to provide great content and programming for the rare disease community. You can also share your feedback via events@globalgenes.org. Up next are two great sessions for you to choose from, either the preclinical modeling or attracting funding for impact. Additionally, we encourage you to check out the agenda for the remainder of the event, including the office hours at 3:30 and the Cure Accelerator. So thank you so much for joining us today, and we hope you all enjoy the rest of the conference.